We're going to move on to session 3 now, which is improving engagement and tackling stigma. We've talked a little bit about this earlier on, particularly around the engagement, but I don't think we've truly looked at those groups that are finding it difficult to report early symptoms of dementia. And I'm very pleased that we're now welcoming 4 speakers to this final session: Dr. Hilda Hayo, Colin Capper, David Truswell, and Sam Rodger. I'm just going to go in that order, and if you could briefly say who you are, and then we'll come to your introductory remarks. So Dr. Hayo first, please.
Hello, I'm Hilda Hayo, and I'm the Chief Admiral Nurse and the CEO of Dementia UK, and we're a specialist clinical charity that we have specialist dementia nurses.
Thank you. And Colin.
Thank you, Mike. I'm Colin Capper. I'm the Associate Director of Evidence and Involvement at the Alzheimer Society. I'm particularly interested in how we involve people affected by dementia in the development of national and local organisational strategies, services and products, and led the development of the Longitude Prize on Dementia, which will bring teams of people across the world together with people with dementia to develop technologies to support them to live independently.
Thanks, Colin. David, we met you earlier, but please introduce yourself.
My name is David Truswell. I'm the a trustee of the Culture Dementia UK, which is an organisation that provides information and support to Black and minority ethnic community members living with dementia or supporting people living with dementia. I'm also the executive director of it's a networking organisation called Dementia Alliance for Culture and Ethnicity, which tries to help and support community organisations who are helping people from different communities living with dementia. I wrote a book called, edited a book called Supporting People Living with Dementia Minority Communities, which collected articles written by myself and other colleagues on specific communities and their experiences with dementia, and some of the issues that were specific for communities and other issues that seem to be common across communities, and spent a lot of the last 10 years or so working in different ways with community organisations to raise awareness about dementia, or working with statutory agencies to raise understanding about cultural issues in dementia.
Thank you, David. And finally, Sam.
Thanks, Mike. Yeah, I'm Sam Rodger. I'm the Assistant Director of Policy and Strategy at the NHS Race and Health Observatory. We're an independent health equity organisation aiming to mobilise evidence to influence policy and practice around ethnic and racial health inequalities.
Thank you. I'm going to keep you all to 2 minutes because we've got a lot to pack in. So Hilda, please go first.
The topics that I'm looking at: patient engagement, person-centeredness, caregiver support, public awareness and education and inclusion, and in particular partnership working. I think everybody's really eloquently covered the vast majority of the population who are older with dementias, but what I haven't heard so much about is for people that are living with rarer types of dementia or younger people living with dementia. So I'm going to look at it from that lens. So with engagement, I think for me, we do involve a lot of people nationally in being the voice of living with dementia, but we do tend to use the same people rather a lot. I think we need to actually widen that out, and I think it needs to be more representative of the people that we actually serve. So across different cultures, different age ranges, and different faces telling their stories. Everything that we do should be person-centered, but of course everybody uses that as a term, as a generic term, but in reality what it means is what works for that individual. So what's the person's strengths, what are the areas that they need development and support with. When I'm looking at caregiver support, we look at the data that's coming back through our national helpline, through our clinics, through our consultant nurses, through our Admiral nurses. And the key thing is the lack of post-diagnostic support, particularly when they're living with the complexities of dementia. They feel that they've been abandoned and they don't have anybody that's fighting their corner, or they don't have the ability to actually get the support that they need, other than getting the first signposting on the diagnosis. So as things get more complex for some families, they find it more difficult to be able to get that specialist advice and support. When we're looking at public awareness and education, I think everybody covered most of the areas, but one place that was actually not highlighted was the workplace, particularly for people that are still in work. Often they're spending large amounts of their time working, and it's the colleagues that will recognise the early symptoms probably quicker than the families are recognising it, or the individual themselves recognise the issues. So I think we need to do far more with the workplace, with employers and with organisations. When we're looking at inclusion and social support, one of the biggest complaints that comes through from the people that we support with young onset dementia is the lack of appropriate care and support for their particular presentation or their particular abilities. And also exclusion from often dementia services that are set up for people over the age of 65. And I think we could do more on that. When we're looking at the healthcare training, we need to do more healthcare training around recognising rarer dementias, atypical responses to dementia, because generally people are looking for people with a memory disturbance. That doesn't tend to occur in the early stages of the atypical dementias or the young onset dementias. And when we're looking at partnerships, I think we need to work truly in partnership and not this fragmentation that Lynn, you so adequately described earlier on, this fragmentation where each different organisation has an element that they're delivering, and the families find it difficult to be able to work out where they should go when they need information and support. So that's what I'm presenting.
Thank you. And you've mentioned some of the areas that we haven't considered earlier in terms of the atypicals and early onsets, and presumably the very rare the children's versions of these as well. Which
Correct.
we're doing. Okay, well, Colin, perhaps I'd go to you next.
Thank you. My first point really is about language and clarity of language. The title for this session references engagement. I think when we talk about engagement, we use language like participation, we use the language of involvement, we use the language of co-production and co-creation, and we're not always entirely clear about what those mean to us and what the differences are between those. From my perspective, my interpretation of involvement and that which I want to apply in the time we've got together today is an involvement that is in the space of co-production, that is working in partnership with people with dementia, whether that's to do with them developing their own care plans or contributing to the development of national local policy or service design. That reflects a move from more of a kind of passive expectation of how we interact and work with people affected by dementia into a more active one. And I think what's encouraging for us is that increasingly that's being done. We're developing much more of an understanding about what meaningful involvement looks like and how we understand and share that. And I think we're going to come on to talk about that later on. I want also to support Hilda's point that if we were to attempt to estimate the number of people affected by dementia who are meaningfully involved in their care or the development of care and services around them that will affect them, it's a very small percentage. We might be at 1% of the number of people affected by dementia involved in some way, which is a tiny number. And picking up on Geraint's point earlier on about the inverse care law, I think there's also an inverse involvement challenge, and that is the people who we should be involving most because they have the greatest need and greatest vulnerabilities and are affected by health inequalities that we've touched on today, are those that we're least likely to involve at the moment. And there's a lot more for us to do to make sure we're hearing those voices and bringing them into the discussions that we need to be having.
And hopefully we'll get to those tricky issues a little later in this session. Go back to David now for his introductory remarks.
Okay. Yeah, I'm going to be fairly focused on something that I think is a huge issue in terms of particularly engaging with Black, Asian and minority communities in relation to provision of information, dementia care, which is the myth that communities look after their own. The African, Caribbean and South Asian communities in particular seem to be often the focus of this myth, despite the fact that their rates of dementia in both those communities appears to be higher than in the white majority population. People may be aware that most people, nearly a third of people over 65 in the last census are living alone. That's men and women. And in the Black, African, or Caribbean or Black mixed category, men and women over 65 are more likely to be living on their own than people in white ethnic categories. There's a more likelihood of South Asian or South Asian mixed folk who are living with other people if they're over 65. However, in those households where people are over 65, therefore, I think we're talking about households that are more likely to be at risk of dementia. If people are living with dementia, the family that they're living with, the family circumstances, they're not extended families. And often, again, it's the presumption that Black, Asian and minority ethnic community families are extended families. So if people are looking after their own, and it's usually a female member of the family looking after an older relative, a parent or an uncle or an auntie, then they're doing that on their own most of the time. And there's likely to be, not in all cases, there's likely to be a cultural expectation that that's their filial duty. So if they're struggling with it, they're not supposed to be asking for help or crying every day or getting depressed, because that's an indication of just how bad a daughter or niece they are in many cases. So even when there is some geographically close extended family, there's still often the situation where the family member who's supporting somebody living with dementia is pretty isolated from the family member support. Some of the work that I've been doing, the vast number of people that I've talked to about this in relation to their experience has been that mainly people are looking after somebody who's got an illness they don't understand, they don't know anything about it, and most of the time when they do see anything about it, it's portrayed as being something that mainly happens to white middle class people, for most of the things they see on the TV or read in magazines. They often have no idea of the psychological impact of supporting somebody living with dementia, what it's going to be like trying to support somebody who doesn't know who you are, trying to support somebody who's accusing you of stealing from them, trying to support somebody who's telling other family members that you're neglecting them. And they're often in a situation where there's a huge risk for both parties that there can be an abusive relationship that emerges because people are isolated and people feel that there's nobody they can talk to, and therefore relationships can be coercive, either because the person with dementia becomes coerced, or the carer feels that they're being coerced, or there may be some sense of which there's financial abuse. But again, for most of the families that certainly that I've had these conversations with, it's very difficult to get outside the bubble of the families to feel you can talk to anybody about it. And also there's often, because of cultural stigma, the experience that certainly the carer and the person living with dementia can become culturally excluded within their own culture, so that you know, it's either they stop going to the church or the mosque, or it feels really difficult when they go to the church or the mosque, or they don't get invited to weddings so much, or they don't get invited to other cultural events so much, or if they go, they feel like they're being a bit shunned because there's this dementia thing that nobody.
David, I'm going to have to do chairman's intervention. Could I just ask if we can make the last point? Yeah, then.
Yes. So, as I was saying, I think there's this enormous preconception about the ability of people in minority communities to somehow sort of naturally deal with the issue of supporting with people with dementia from their communities, that needs to be addressed when we try to think about how we reach out in order to support both carers and people from those communities with the information and support needs that they need, and to provide those things on an individual, personalised basis.
Thank you, David. And finally, Sam, if you can be brief.
Yeah, of course. Thanks, Mike. And yeah, I mean, like David, really unsurprisingly, we're quite interested in ethnic inequalities in dementia care, not least because we know Black and South Asian patients tend to be diagnosed with dementia at a younger age and die at a younger age, but also that they tend to present later to specialist diagnostic and therapeutic dementia services. And there's a couple of different forms of engagement that I think are important here that hopefully we can kind of tease out a bit in the next session. There's, of course, we've heard a lot about the kind of interpersonal engagement that happens at the point of diagnosis and in treatment and care thereafter with people and their families and carers. And there's quite rightly a drive to make that more person-centered, as we've heard, but I think there's still questions that we're looking into around how we can make that person-to-person care adaptive according to culture. But I think it's also important to think about different forms of engagement. So there's engagement at a national level in terms of the communications and guidance that are put out into the world by national policymakers around how we destigmatize conversations around dementia. And then there's the community engagement and participation that happens at a policy level, which informs service design and provision and local level communications. And we've done a lot of work around good community participation and engagement. And the principles are probably familiar to everyone here. It has to be two-way, it has to be empowering, it should be long-term. But I think most importantly, and the thing that ties all those forms of engagement together, is questions about trust, which we as an organization are starting to explore as a structural determinant of health in itself. And recognizing that trust can't just be summoned up with goodwill, it's something that needs to be earned and tended and maintained. And I think when we're talking about trust and engagement with ethnic minority communities, the elephant in the room sometimes is that it's just more expensive. There's a huge trust deficit to be overcome, different barriers to engagement than we have with majority populations. You know, we've been involved in lobbying for an ethnicity boost to the adult psychiatric morbidity survey recently, which very nearly didn't happen on the basis of cost. And really, we need to recognize that it's not good enough. And unless we're serving all communities together, then the NHS isn't working for those communities. I'll stop there. I think I'm at my 2 minutes.
Thank you very much, Sam. And we're going to speedily go into the questions. And James, you're going to kick us off this time.
Thank you. And I'll apologise in advance for limiting this just to two people for the interest of time. But if I could to ask Colin and Sam, I want to ask a question about policy making, as you're both sort of directly involved in the process of policy making, and how, as policy makers, people at either the central of government or at local level, wherever it is, can do a much better job of involving the broadest possible range of patients and carers in the policy making process, so that it feels connected to that experience that we've been hearing so much about. And of course, that in itself is highly diverse, rather than being done in the kind of classic Whitehall or Westminster ivory tower. Colin, could I ask you first, and then Sam, perhaps?
Sure, thank you. Well, I think there are a set of principles that apply to involvement that apply in the policy making space. I'll run through this very briefly, and we can expand later on at the time if needed. I mean, the first I think is recognizing the value of the expertise that people with lived experience brings. And valuing that equally, if you like, alongside the professional expertise that others in policymaking might bring. Scotland has recently published its 4th dementia strategy, and in the development of the Scotland dementia strategy, a lived experience panel was established at the beginning of their process and worked alongside an advisory group, and there were clear processes applied for dialogue and consensus reaching, which I think is a really interesting example of how we put these two sets of expertise alongside each other. I think with that, we need to acknowledge that there's some type of redistribution of power as part of co-production and working in partnership with people with dementia, and that means a change for some, and how we navigate that and understand that. Clarity around decision making and accountability in those governance processes feels important. We need to be clear about what the purpose, the outcome, and the process of involving people is, clear goals and approaches to that. And I think that's where the idea of, if you like, democratizing involvement is relevant. Again, an example from Scotland, the team developing the strategy in Scotland, with the help of Alzheimer's Scotland, went on tour and took 5 simple questions that informed the development of Scotland dementia strategy out to people in communities who otherwise wouldn't be reached. So this idea of not offering people a seat at the table, but taking the table to them, I think is particularly important in this. We need to give time and resource, as Sam was saying, to build the trust, the relationships, the communication, and the dialogue that's necessary. And finally, for me at least, ensuring we're evaluating, we're learning, and sharing impact. And I think that's on a number of levels. It's about the experience we have personally of being involved, and have the experience people with dementia have of being involved. It's what we learn from each other in that, in both directions. It's, you know, what changes as a result, and ultimately what changes in terms of the impact this might have culturally or on a system. And part of that needs to be, talking to David's points earlier on, thinking about equality and impact assessment. Who are we designing for? Are they round the table with us? Ensuring we're bringing those perspectives. So those are some principles, James, that I think apply in that.
Really helpful to have both the principles and also to see them in, or to hear about them in practice in Scotland, which we can look into, or if you can send us more details, that would be terrific. Sam?
Yeah, I mean, I agree with everything Colin said. It's absolutely about transparency of aims and engagement. And when I talk about it being kind of long-term and meaningful and two-way, I think, you know, there's always been a problem in engagement where you talk to a community about the issues they're facing, and then, you know, that's the last they hear of it, and there's not time taken to kind of then validate the kind of conclusions and recommendations that come out of the exercise, and to actually involve them in the production of the services, or whatever it is, the policies they're feeding into. I think the other thing that's really important, that I've already alluded to, and this is, you know, not what anyone wants to hear in a stretched system, but it really is about resource allocation. Because even if you're trying to engage equitably and sort of making sure you've got a room full of people from minority ethnic communities, it does take time and money to really make sure those are the right people in the room, as I've seen someone sort of mention in the chat now. And it does mean going into areas where you haven't spoken before, and going door to door and really trying to engage in different ways. And this comes back to stigma, I think. And, you know, we saw a lot around COVID-19 vaccinations, where any pushback against the vaccinations that was seen to be informed by a kind of cultural reservation around the vaccine was dismissed in kind of national communications and policy making. And so if you allow that time to engage actually with concerns in a really kind of meaningful and open way, and not kind of dismiss them from our kind of Western centric clinical and policy making point of view, only then you're ever going to start breaking through those barriers. And finally, to say that it's really important, not when we talk about stigma, not to fall into a kind of deficit model, where, as I say, the issues that are seen as cultural are blamed on the communities who are being underserved by the system. It's the same way we think about the social model in disability. We just need to start from a place where we're looking at the system as creating barriers and not at communities as having issues accessing the system.
James, you come back on that, or are you happy with that?
No, that's terrific. Thank you.
Thank you both. Karina, we're going to talk about sort of partnerships a bit more now, and I know you've been posting things as well. Do you want to go ahead with your questions?
Yes, so I will ask Hilda first, then David, please. So I think, in a brave new world of ICSs, we've all got to learn to work together in new ways. So how can we kind of foster that effective collaboration between providers, advocacy groups, community groups, and policymakers, both to kind of make sure the services are working, but particularly in the context of this session, make sure we're addressing the stigma and improve dementia care. So Hilda first, please, then David.
Well, certainly we were linking in with the ICSs and the ICBs in order to highlight the complex issues that families can face with dementia. So we're going to the people that are on those boards and in those services. We're doing that from a national level, particularly across England, not quite so in Scotland and Northern Ireland, but we're certainly focused on that area. And we're working with some of the boards in Wales as well. I think what people tend to be interested in ICSs and ICBs is what model is going to be the most cost effective. And what we try and put across is what the cost effectiveness is of a particular model, but also what the human cost is as well, and what you can do differently around post-diagnostic support that actually will save money in the long run. It's also about making sure that getting the diagnosis isn't just focused on one particular age group, on one particular select section of society. It's actually opened out more. As I said earlier, there's a difficulty with people recognizing atypical dementias or having the ability to understand that actually not everybody will go to primary care if they're facing issues. Linking back to some previous conversations, community pharmacy, working with dentists, working with opticians, working with people in those local communities, which is at the heart of what ICSs and ICBs should be doing, should be important to enable people to go and seek advice and support when they're facing difficulties. Often people are reluctant to get the advice and support around a possible diagnosis of dementia because there's the fear and there's the lack of hope. So therefore we need to be doing a lot more about that as well, and not helped by front pages of certain newspapers putting the fear factor into the diagnosis of dementia.
Thank you. David?
I don't think one size fits all, and I'm very wedded to the idea that it's about local solutions for local circumstances. And as an exemplar, I'd use the Dementia UK's recent innovation of creating a Chinese-speaking Admiral nurse in East London, and that was heavily influenced by the support of Chinese community groups, but also recognized that there was quite a significant proportion of the people in the area that it was focused on. And in the recent paper written by the developer of that particular initiative, they were saying there's no point if there's hardly any Chinese people in your local community going through this particular process. It's not going to help. It's not a good use of resources. But I think in different communities that there will be different infrastructure in terms of the relationship with community organisations. I think it's essential that these things are grassroots. I think it's essential that they're co-productions. I think it's essential that from the get-go they involve the experience of people living with dementia and their carers and community organisations to think through the best way of getting the best results. I'd also flag up the issue that, again, if there are particular communities that are at higher risk, we need to focus those resources at those communities to reduce those risks. This is good public health practice. So it's not about favouring communities. I think sometimes it gets expressed in that way. It's about risk. So from the ground up, local solutions, there is no fix that works for everybody. It's got to be bought into by everybody in the locality who's going to be involved in creating something that works within the resources that are available. There's no other way, in my view.
Thank you, David. And I think that's right. I think this grassroots, this co-production tailored to local needs and taking into account local experiences, that has to be the answer. Now, Mike, do we have time to go to Colin just very briefly?
Yes, we do.
Perfect.
Yeah.
Thank you, Corinne. Just a very, very quick point building on that. I think we all will understand and recognise the complexity of dementia. And I think there's a starting point for collaboration in me, in that recognition, and the fact that the more perspectives we have round the table to help us to understand the challenges at a local level and create the solutions that will help to deliver that, the better. I think with that though, and what I hear from people affected by dementia is them wanting to have a shared accountability, a shared responsibility for driving change, and them being active in doing that and taking that ownership, if you like. And I think that's something that we don't necessarily see a great deal of, that sense of shared responsibility and accountability at a local level to drive change. And I think there's an appetite for that we could be harnessing.
So, thank you, Colin. And any comeback questions you want to come with, Corinne, or are you happy there? You're on mute.
Sorry, I was only going to say, I think it's over to Jill now.
Okay, Jill, for our final question in this session.
Thanks very much. It was just picking up particularly on that bit about tackling stigma and what we thought the stigma was about, really. It could be simply the name of the diagnosis. It could be the fact you are referred into a psychiatric service. I think that's an issue, particularly for older people. It could be the stigma of practical implications, like not being able to work if you're younger, like holidays, like driving. It could be all those things. And it can also, ironically, be blame. You know, you've caused this disease yourself because you smoked, because you didn't take enough exercise, because you were overweight. We've seen that particularly with lung cancer. We did such a good public health job of saying smoking gives you lung cancer that it actually has much less sympathy as a condition than other things. So I just wondered about unpicking the stigma in the context of, therefore, how do we help? How do we address it? And do those things resonate? I don't know who I should turn to for an answer, but perhaps Hilda first.
Yes, the stigma of dementia. I always cast my mind back to when I was giving diagnosis to people, younger people living with dementia in my nurse consultant post. And often people would say, oh, it's Alzheimer's. Oh, that's brilliant. I thought it was dementia. Or it's PICS. Thank goodness it's not dementia. So I think there's a massive lack of understanding. Despite all of the health education, despite everything that we as charities and organisations have been doing, I think people are still a massive misunderstanding of what dementia is, i.e. the umbrella term, and the specifics underneath. On top of that, I think, as I said before, it's about fear. People are frightened of dementia. It's one of the most feared disorders after the age of 40. So in some ways, that might be something that we can utilise effectively for preventative work, particularly for the families that are living with the effects of dementia. So I think that it's trying to get the balance right between saying these are some of the things that can happen in dementia, and also trying to keep the message where it needs to be so that people are not afraid to go and get the diagnosis. There's still a fear that when you get the diagnosis, as soon as the person has told you what it is, you can't drive anymore, you lose your job, particularly in the age range I deal with. And on top of that, your family make all your decisions and you'll probably go into a care home. That is still there, despite everything we've done, all of us as organisations. That misperception is still there. We've still got a lot more work to do on that.
It's really interesting. Have we got time for more answers, Mike?
Just briefly, one more.
Oh, I don't know, perhaps you've got your hand up, David, and I would be interested in the
just quickly, because I mean, I think just one of the things in discussions more recently talking about creativity in dementia is people want to have fun. People want to kind of feel they could be creative. People want to feel, at least today, we can be hopeful. And I think that's part of what one has to have in this context. It's not just only about how awful it is, not because it's not awful, but there are other things that folk want from their lives. Find it now.
Interesting. Yeah. And of course, at some point with an effective treatment, that will help, won't it? That will make a big difference. Anybody else want to come in, or yeah, Sam?
Sorry, yeah, just very quick final. I think it's really important to separate out stigma and fear around dementia with what can just be cultural differences in terms of conceptualizing aging and mental health, and by extension, dementia as well. So there's a real case for more sophisticated, culturally adapted diagnostic tools and therapeutic tools, especially I think around first generation migrant communities, for example, where I think this is a problem just in kind of not really thinking about aging in the same way that our clinical systems currently do.
Yeah, no, good point.
Thanks, Jill. Well, we come to the end of this 2-hour webinar. It's about it seems to have flown by, which usually means it's been very good in my view in terms of input. I'd like to thank the panelists on the final session, Hilda, Colin, David, and Sam for your contributions, and to my colleagues for their questions. James, I don't know whether you've got any sort of final summing up points you want to make, and then just to let you know, this will be available. We've recorded it, and if there's any other submissions you wish to send us for our commission, we'd be very happy to receive them. And thank you all who did contribute. But James, I'll give you the last word.
Thank you, Mike. I mean, an impossible task to sum up such a rich discussion, but some of the things that jumped out at me, I think we've talked about joining up care and capability across health and care, but this kind of idea of extending that idea right out into the population so that we are all to some extent trained, or at least educated, to understand what dementia is and what one might do about it, with sort of escalating grades of sort of sophistication about the interventions that can be given as we professionalize it, but not forgetting the role of the public, families, carers, and all of that. The importance of data, a topic we come back to, of course, but being able to join that up both for diagnosis and for the delivery of care. The sort of fundamental point about the involvement of patients, carers, and the public in care service design, and of course the policy making process, because this isn't like a normal disease. This is much more, although of course the experience of it is deeply personal, this is much more of a kind of social phenomenon, and therefore we need to take great care in how policy making is designed here. I think some really helpful principles about the use of technology, where it can be most useful, how it should be used, and how it could be funded and commissioned. I like this idea of a goal of, thinking about dementia in the context of closing the healthy life expectancy gap, and indeed raising the bar on that, given, as we heard at the beginning, that life expectancy is stagnating. And of course, always trying to walk this fine line between taking a universal approach to a service or to dealing with a problem that will affect so many people, and then at the other end, personalization, so that we really take into account the factors about a person, their lives, and so on, so that they can get the care that's going to, and treatment that's going to work best for them. So lots of us, for us to unpack, to follow on from this, and amazing contributions to the report that we will produce in the long run. In terms of what's happening next, we've got another session in July, which I hope many of you will be able to join us for, around care pathways, and in September, a much more sort of design focused sprint around pathways, which again, I hope many people will be able to contribute to. But yeah, I just want to finish, Mike, by adding my sincere thanks to yours for our speakers, to our partners, Lily Roche and the Alzheimer Society, and of course to you and the fellow commissioners for another really interesting session. And I'm very grateful to everybody who's contributed on this call, one form or another.
Thanks everyone, and thanks for the summation, James.
Take care. Thanks.